So today the topic was bronchial artery embolization. Before I start, I would like everybody who's attended our previous classes can, if anybody has any questions in that duration, if you have read up something and uh, you want to ask, then maybe we'll have a couple of minutes before we take up the topic. Um, I mean, in intervention radiology, the first thing that is different from maybe the entire rest of radiology is that you have to start thinking like a clinical person. Of course, imaging is important, but it is more of a procedural science. And if you do a procedure, then you are responsible for what happens. So you're not just responsible for the report that you send, but you are actually responsible for the treatment. And hence, it is very important that we not only understand the imaging and the procedure, but also the part before it, because these procedures will stay with the IR only if intervention radiologists take up the role of a clinician, become the face for the patient, talk to them, assess them, and be able to manage at least something. So it's not something which is very difficult. If you see ortho guys who are doing knee replacements and joint replacements, their medical knowledge is not great. It's just that they kind of take that up, take consults from everybody else, get clearances, and they do their job. So similarly, that much work you should be able to do, that if there's a problem, you should be able to take an opinion, you should be able to deal with it, you should be able to pick it up. Otherwise, it's not that every detail has to be known by us. Everybody works like that, but you need to have the patient's confidence, and you should have the best interest of the patient at mind. So with that in mind, we'll start today's talk. And the first thing is we'll be discussing, in bronchial artery embolization, why we do the procedure, what are the anatomy of the bronchial artery, what are the normal origins, what are the variant origins. Then what are the pathological features that you look at the DSA or the CT angiography that we do, how to recognize that it's a abnormal bronchial artery that needs to be treated. The diagnostic workup techniques. Basically, then the main important thing would be how to do the BAE, with what to do BAE, and if you do a bronchial artery embolization, what is the possible complication. So bronchial artery, embolization is a minimally invasive technique, which again, it goes for all IR procedures. That is the first gold standard thing that goes in favor of any intervention radiology procedure. This was first described in the 1970s. And the best thing about it is the short-term follow-up up to 1 month. The recurrence rates are quite small. So usually we do it in a temporary manner. If you want to take care of a patient who's having hemoptysis, massive bleed, we just want to make sure that the bleed stops. Then we can figure out what the problem is, give the medications accordingly. Is it an inflammatory disease? Is it an infective cause? So the first thing is to just make sure that the patient survives. And then sometimes that itself is definitive because there is an aneurysm or there is an AVM, which primarily is definitively treated by the bronchial artery embolization. But sometimes, the it's a temporary measure so that rest of the disease process, which was causing the hemoptysis or the inflammation to cause in, hypertrophy of these bronchial arteries, is taken care of. This is an example, this image here. Uh, So this image here, it shows this kind of a tortuous hypertrophied bronchial artery supplying the lung parenchyma. And after the embolization, you can see that this vessel is not really showing any forward flow. So the flow stops. You've injected something which has made it to stop. That's an embolic agent, and we'll be discussing that in some time. So it could be temporary or a definitive process. So the difference between patient going up for a lobectomy or a surgical management versus BAE is usually BAE we do for massive hemoptysis because we don't really have the time to understand where it is bleeding from, what to do for this patient, and the patients can actually drown in their own blood because basically you see how you drown your blood, you aspirate water, it goes into the lung, but if you're bleeding from within, it becomes a big problem, and even a small amount of blood can lead to a big problem. And deteriorating HB or other parameters and a massive bleed. These are basic tire where definitely you should quickly take up the patient for BAE. Recurrent hemoptysis may be, not as massive, but mild to moderate, happening repeatedly despite our best efforts to control that medically. So patients with high risk of, asphyxiation, they are not, they having this hemoptysis, and maybe they're not having very good control. Neurological patients who are not able to cough things out properly, some nerve involvement that has been there prior. So they're at higher risk of asphyxiation. Those who are not fully conscious, so basically it does play a role in those patients, because even a small bleed, they will not be able to, throw out the blood. We often use it to stabilize patients before, as I already told. And again, that will always be there, a refusal for surgery, patients not fit for surgery. So that's like a negative for the opposite procedure, which also become a positive for bronchial artery embolization. Similarly, surgery, when the patient is not really bleeding massively, we have figured out on investigation that there is a single lobe where is a disease is localized and it is bleeding from there. So there is an aspergilloma in that area, which is causing inflammatory reaction around it, and it is bleeding. Or there is an associated small aneurysm, which we feel that you can remove the entire thing from that location. Then surgery is a very good option, especially when the patient is not actively bleeding massively. I mean, the amount of bleed is not very high. Multiple arterial diseases, you can't really take care of all of them. Of course, an angioembolic procedure is contraindicated. Relative contraindications will include, allergy to contrast, high hypercoagulable state, where you feel, you can't really do these procedures. Mostly, there is no real absolute contraindication for these procedures, and patient is responding to BA. So that again becomes a negative for the opposite procedure is an indication, but the absolute indication for surgery is localized disease where a lobectomy or one side of lung can be removed and the condition can be totally cured. So source of bleeding you have to understand can be either uh, bronchial circulation, pulmonary circulation, or non-bronchial systemic supply. So first we divide it into two parts. So whether it is systemic or pulmonary circulation. So a systemic circulation can be further divided into bronchial and non-bronchial ectopic. So we'll be discussing that. So 95% of the time it is the systemic supply which is the source of bleed, and importantly because the systemic blood pressure is much higher. You're having a systolic blood pressure of 120, 130, which is much greater than the systolic blood pressure of the pulmonary circulation, which is around 20. So, that's a 6 times different in the pressure. So, of course, there is higher chance that the bleeding would happen from the systemic circulation. The problem with surgery is in emergency cases, the mortality is very high. You're trying to do a surgery in an emergent situation, the mortality rates are very high. Uh, and if you conservatively treat massive hemoptysis, you don't do surgery, then also the mortality rate is very high. So you have to do something which has a slightly lower mortality rate. And that's what happens in short term to avoid mortality with surgery or just conservative management. We do BAE so that we can figure out in the long run what is the definitive management. The good thing about this is even if you have a recurrence in the long term, the patient doesn't have a disease which can be cured surgically or not getting controlled medically, you always have an option of repeat embolizations. Minimally invasive, maybe 6 months, 1 year, 2 year down the line, you can again do a repeat procedure if the patient is having a bleed. The next part is to understand, whenever you are able to, embolize an artery, you have to understand that you are cutting off the blood supply to that region. So either you have to very careful and really embolize very small part of it, or there is something in the body that allows you to embolize the artery without having a problem. So this is the principle which is there in liver and that is there in lungs because of the dual supply. So the dual supply of the bronchial circulation and the pulmonary circulation allows us to take off one of the vessels. So as we've already understood that 95% of the bleed is from the systemic circulation, then of course if I have to cut down one of them, then I will cut down the bronchial circulation. So if I cut off the bronchial circulation, then there is a higher chance that whatever was causing the bleed will stop. So the bronchial circulation is primary from the aorta. As I said, it's a systemic circulation, and the pulmonary circulation is on the right ventricle. So that describes the difference in the pressure. So what comes from the left ventricle will have the similar, higher pressures. Causes of hemoptysis is what you need to understand. See, this is something very, very important. Somebody will come to you